So Dr. Lipton, coming from Houston, Texas, received his Bachelor of Science degree from the University of Michigan and continuing his DEDS in Michigan as well. After the dental school, Dr. Lipton completed a one-year advanced education in general dentistry at the University of Florida with a focus on full mouth reconstruction. And then he completed 3 years of maxillofacial surgery. But then he decided to switch his specialty to periodontics and returned to the University of Florida College of Dentistry to receive his Master of Dental Science in Periodontics, as well as in extensive clinical training in regenerative periodontal therapy, soft and hard tissue reconstruction, aesthetic periodontal procedures, as you will see later on in this webinar. So without further ado, I would hand the mic here to Dr. Lipton.
Thanks, Ziv. It's an honor to be in a webinar with you and Bob. So tonight we're going to talk about navigated guided surgery, optimizing implant placement, and thank you for VuMedi and claronav for hosting and sponsoring this event tonight. If you don't know, I'm coming from Houston, Texas, and we'll get started. So just disclosure, all the images were only cropped or adjusted for brightness and exposure, and I have no financial ties to claronav and have not received an honorarium for this event. So when you see these radiographs or clinical images, and we're thinking of navigation, it's getting from point A to point B. I look at these photos, and in my mind, the surgeon went left when they were supposed to turn right on their navigation of their implant placement. So tonight we're going to talk about navigating surgical guides. We're going to talk about accuracy and precision and how it relates to implant therapy. We're going to mention what dynamic navigational surgery is, and within that we're going to focus on the Navident system. We're going to review a couple cases illustrating utilizing the Navident system, and then we're going to tie it all together. So when we think of navigation, where I put the analogy is back to when I first learned how to drive. Had to use a paper map, and you map from point A to point B. You unfold it, you open it up, and that's how you got around. So to me, that's equivalent to where we would make an impression, we'd pour up a model, we'd do our model surgery, we'd have a clear suck down, and then we transfer all of that to the patient's mouth and do our surgery in the mouth. Well, we know technology advances, so what came along with navigation were these third-party devices that would give you digital navigation that you could take from car to car, but you had to go to the store and purchase it. Well, that was similar to our surgical guides that we would purchase from a company that would mill them and then would ship them to us, which would take anywhere from, a week to 2 weeks, depending on where you would get them from. But of course, technology has continued to advance. Now we have navigation in our car, where it's giving us nothing that we have to take in and out. It's just built into the car. So what does that equate to dental surgical guides? Well, now we have 3D printers where you plan it on your computer, you hit print, an hour to 3 hours later, you have your guide. You don't have to leave the office or send it off and wait for it to come back. But of course, as technology continues to advance, we now use our smartphones in specific applications that will give us our navigation, but in real time, giving us updates to get us from point A to point B as precise and accurate as we can. Well, are there surgical guides on the market that can give us real-time feedback? And the answer is no, but what Bob and I are going to show you tonight is actually going to give you real-time feedback without using a true surgical guide. So when we think of implant placement, we want to know what accuracy and precision, because we want to do what's best for our patient as well as our restoring docs. And if you're the restoring doc, what's best for in making your life the easiest. So accuracy is defined as the quality or state of being correct or precise, whereas precision is the quality, condition, or fact of being exact and accurate. So if we put this into a picture in a bullseye where everyone can see, in this image we have no accuracy and no precision. We have accuracy, but we're not precise. We are very precise, but we're not accurate, but what we're always striving for is accuracy and precision. So when you're placing your implants, do you want to be accurately accurate or precisely inaccurate? And we know from Schneider's systematic review in 2009, they looked to analyze the literature on accuracy and clinical outcomes of computer-guided template-based implant dentistry. Those are the static guides that we've been accustomed to for the last 10 to 15 years. They evaluated over 3,100 titles and narrowed it down to 8 articles that met their inclusion criteria. And what they found was that the average entry point deviation was 1.07 millimeters, and the average apical point deviation was 1.63 millimeters, with a maximum of 7.1 millimeters. So I want you to keep those numbers in mind as I illustrate a couple cases at the end of the presentation. And they concluded that there were a considerable number of technique-related perioperative complications observed. So is there a way that we can become more accurate and more precise without having to use an actual surgical guide or template? And that's where dynamic navigational surgery comes in. And what it is it's a system that is empowered by motion tracking technology, which tracks the position of the patient, drill, and implant in real time during the surgical procedure for ideal precision and accuracy. Now, there's several of these companies on the market, but we're going to focus on Navident today and how I implement it in my practice and how we use it and how it is used. So with the Navident system, it comes in multiple parts, but the first part is a cart, a computer, and the camera. You also have a head tracker. You have a calibrator, a tracer tool, and a drill tag. And these are the components that you need in order to perform implant surgery with the Navident system, and it's all packaged together. And now we're going to illustrate how all of these are utilized together. So a typical sequence of events is a patient comes into your office and you obtain a CBCT. You take that CBCT and you put it into the treatment planning software that comes with the Navident system. And it's just like any other third-party software where you can see if it's a straight implant, a tapered implant, the width, the diameter, the length, all of that can be customized to any implant system size you use. So now it's surgery day. The patient comes in, they're prepped and draped in whatever manner you do in your office. The head tracker is then applied, and it fits around your ears and sits on the bridge of your nose. And this is essentially what our static guide used to be, and this is what it is now. This essentially is your surgical guide. You now have the tracing and accuracy check, and this is what's allowing the mouth to communicate with the computer all through fiduciary markers on the tracer tool and the head tracker. And what you're going to do with in these cases are you're going to select X amount of teeth. You're going to trace them until you get to essentially 100. It's going to bing and you move on to the next tooth. If for some reason it's not doing it, you're going to choose new teeth and continue going until you've met your criteria. But you need to make sure you trace correctly. So now you're going to perform an accuracy check. And this is what's correlating what you're doing in the mouth to what's going on in the computer through the fiduciary markers as well as the camera. Now it's time to start your implant osteotomy. So you're going to calibrate your drill. And ideally, in theory, if all the drills are the same length, you only have to calibrate once. However, in my office, we calibrate after every drill. It takes no more than 5 to 10 seconds, so it's not like you're adding minutes or to time to your surgery. But once again, you're going to perform an accuracy check because you want to make sure nothing changed from the time you calibrated to the time you're going to do your osteotomy. And now you're ready for your guided drilling and your implant placement. And this is what you're seeing in real time in a three-dimensional view, exactly where that drill is going for your osteotomy preparation. So this is our first case, and this is Jen. And Jen presented from the endodontist and her general dentist with a hopeless number 8 due to internal resorption. So this tooth was removed in an atraumatic manner. We performed site preservation with the materials that we use in our office. And after 3 months of healing, the patient obtained a CBCT. And with that data, we then started to plan our implant placement in site number 8. And utilizing all the views, we were able to guide and place our implant through the 3D through the software to the ideal prosthetic location that we felt comfortable with the restorative doctor. The patient's now brought in and prepped and draped, head tracker applied, and now we're calibrating our tracer tool. And once again, this video illustrates where we're just tracing one of the teeth that we selected, and once that's completed, we're going to move on to our accuracy check to confirm what we're touching in the mouth is correlating to what's going on in the computer. If for some reason it's not matching up, we're going to go back and retrace again, which takes no more than 60 to 120 seconds to do the tracing. It's a short, quick thing. Now we're going to calibrate our drill tip. We're going to drill our osteotomy. We're going to do another accuracy check to once again make sure nothing moved. And now we're ready to perform our osteotomy. And this is the screen that you're going to see as you're drilling. And this is real-time feedback of what you're drilling is exactly what's going on the computer screen. And there is a learning curve looking at a screen instead of looking at a patient. But once it clicks, it's very, very easy to make that transition, but there is a learning curve. We then calibrate our implant, and our implant is also placed using this dynamic navigational surgery so we can get the implant placed in the exact place we drilled it. Now, when you look at this radiograph, it looks good. Now, could we have done it freehand? Yes. Could we have done it with a static guide? Yes. But how accurate and how precise could we have been based on our initial planning? Well, within the software, our patients get a postoperative CBCT, and in that postoperative CBCT, we put it into the Evalunav program, which in this first image shows where the implant is, and the yellow is where it was planned. The red one is where the actual implant was placed. And then the software merges these files and overlays them so you can sort of see where it was planned to where it was placed. But what's really nice is it gives you data. And in this case, we were 0.5 millimeter off at the entry, and we were 0.5 millimeter off at the apex, which to me is more accurate and more precise than what Schneider found in his systematic review using static guides for implant dentistry. Now, the second case and final case we're going to present, this was the second case that I completed in my office, and this was before the trace in place, but it illustrates how important dynamic navigational surgery is for all cases that we utilize it in. So this is Ryan. Ryan is a 21-year-old college student who goes to school out of state, so it's a plane ride away. And at the time he was ready for implant placement, mom and dad did not want to pay for it or have him go through the surgery. And they didn't want bonded Maryland bridges in because if something popped out, he was 8-9 hours away, wasn't going to come back, so that he had a transitional partial denture. But he finally convinced his parents to allow him to get 2 implants placed. Now, when we look radiographically, we got a really, really narrow space, and this is after orthodontic, and this is all our orthodontist could move these teeth in line. So we did an optical scan with the digital wax up and merged the STL file with our CBCT, and we started planning the surgery. And we knew in this case we had to be as accurate and as precise as we possibly can because we didn't want to damage any of the adjacent teeth. So this is our plan, and this is what it's going to look like when we started drilling. And like I said, this was our second case we completed, so we were still learning exactly how to use the software, and we were taking our time, but we knew we had to be accurate and we had to be precise. So clinical photos shows how narrow and how deficient we really were in these sites to get a couple implants in. So we flapped it, we did our osteotomies, we actually put the drills in and took some x-rays to confirm exactly where we were. We were new to the software. Still check and balance. Occlusally, you can see this is exactly where we planned our osteotomies. And when you actually look at the radiographs, I'm not confident we could have done this freehanded, and even with the static guide, knowing our literature, if we were off 1 millimeter, we were buying ourselves an extraction and another implant adjacent to that. So dynamic navigation thoroughly worked for accuracy and precision in this case. Now, this is a little misnomer because we originally planned for deeper implants and longer implants, and we changed our plan. And that's another critical aspect of this software is you can change your surgical plan on the fly, whereas in a static guide, you have no control. Whatever you planned is what you're getting. And in this, you can change it and continue going back to your osteotomy. So we continued through the digital workflow, and these images are courtesy of our restorative doc. And looking at the final result, we got it screw retained in the right place. Aesthetically, could have probably used some gingivectomies, but overall, this is a 22-year-old now without a transitional partial denture, has fixed appliance in his mouth, and he can go through the rest of his senior year of college enjoying life. So overall, it's a beautiful result using dynamic navigational surgery. So what's next in our office? Well, Navident is creating new calibration tools for endo, for piezo, and other modalities, and now my office is starting to get into full arch implant placements utilizing this dynamic navigational surgery. So in summary, surgical guide fabrication is no longer needed. Real-time feedback of osteotomy preparation and implant placement for better accuracy and precision during implant surgery, and changes to the surgical plan can be made in real time during the surgery. And with that, I'd like to thank you for your attention.
Well, David, thank you so much for this marvelous presentation. Before we move on, I have just one quick question for you. Are you still using stereolithographic guides, or you shifted totally to dynamic navigation?
We have not shifted totally, but we have progressively moved to using the Navident system much more now than we did in the past. And because we don't have our own 3D printer or milling machine, it's been a huge benefit to be able to use this than have to order a surgical guide and wait for it to come in the mail, as well as emergency visits that we want to do immediate implants. We get a CBCT, and then, within 20, 30 minutes later, we're already operating. So that's where it's really come into play for me and my partners in our office, is more the anterior aesthetic cases in the same-day emergencies that we would usually get a guide for, but now we have our built-in guide with the Navident system.
Well, I have a feeling that the more you do, you will become addicted. That's for sure.
Yeah, we definitely are addicted, but we're still learning like everyone else. But it's definitely been a game changer in our office.